let's get started with our agenda. We'll recognize all of you as visiting. I guess we'll find out why you're here later, or you can announce now, I guess. But anyway, moving forward, any other, we don't have Senator Dockstead or anybody I need to recognize from a higher power. Okay. Minutes of March 25th meeting. I'm looking for a motion. Anybody have any amendments or changes?
To approve.
Moved by Mindy to approve.
I'll second.
Second by Jeff. I heard this first. Any further discussion on the minutes of March the 25th board meeting? All those in favor?
Aye.
Any opposed? Okay, minutes been approved. Any changes to the agenda? Anybody have any? Everybody's read through the agenda. Then I need a motion to approve.
I'll make a motion to approve. Second.
Moved by Abby, seconded by Mindy to approve the agenda as written. Any further discussion? All those in favor?
Aye.
Any opposed? Motion passes. Now ready to turn some time. Who's handling the, Sadie is. Our recognition of star performers. Maybe this is why you are all here. Come up there.
Okay, so my name is Sadie. I am the Vice President of Quality and Patient Safety. So we do star performers. We used to do it monthly. We switched it to quarterly. So the way that it works is anybody can nominate a staff member, and all those nominations go to our Employee Appreciation Committee, and they're voted upon. So we have 3 for Q1 of 2026. So I would like to call up Laura Valentine, George McCaffrey, and Dominique Blaine.
Come stand right over here.
Okay, so we'll start with George. George is being recognized with a Star Award for demonstrating exceptional teamwork and dedication in a moment when it truly mattered. With nearly 2 years of service at Star Valley Health in the IT department, George went well beyond normal job duties on a Friday evening when a med-surg ward clerk computer crashed after a spill. As he was heading out for the day, the situation was brought to his attention, and without hesitation, George stepped in, coordinated with IT, and personally stayed late to swap out the computer and ensure operations could continue smoothly. This support came outside of the employee's usual clinical IT role, but it made a significant difference for the care team, especially heading into a weekend. This action exemplifies service, teamwork, and a willingness to go above and beyond, and we are grateful to recognize George as a Star Award recipient. We also want to recognize George for his work in his new role as a business intelligence developer. He has played a key role in providing the data and reporting that enables our organization to reach the next level, consistently delivering reports with impressive speed and reliability.
Business intelligence. This is the best side.
There we go. Thank you.
Thanks, George.
Okay, Dominique. Dominique Blaine is being recognized with the Star Award for outstanding service and compassion shown to our patients and community members. With nearly 4 years of service at Star Valley Health in the Revenue Cycle Department, Dominique consistently demonstrates professionalism, empathy, and a genuine commitment to helping others. A community member recently shared how overwhelmed and frustrated they felt while navigating a complex insurance billing issue, and how she took the time to truly listen, provide reassurance, and clearly explain the steps needed to resolve the concern. The patients knowledge, and care shown made a lasting impression and turned a stressful situation into a positive experience. In addition to exceptional patient service, Dominique is also recognized for mentoring and training colleagues with calm guidance and clarity. This dedication to both patients and our team reflects the very best of our Star Valley Health values, and we are grateful to honor Dominique with a Star Award.
Congratulations, Dominique. Thanks for all you do.
Thank you.
Okay, another picture. Get it?
Yes.
Thank you.
Laura here.
We're missing Laura.
That is a true star performer. Okay, we will wait to recognize her until next month when she can maybe join us.
That'd be great.
Okay, thank you.
And while you're all here, thanks for all you do. We appreciate it. Yes.
Read. Oh, no more.
Do you want to say something, Doc?
Sorry.
You raise your hand, you get called on here. Okay, let's move on. Chief of Staff. Notice you're in the crowd.
Everybody. Please, Martha, you're with me. I'm gonna stand right here. Okay, is everybody in? You can come? Yeah, come on in.
Coming in.
We got plenty of room.
Yep.
Lots of room right here in the middle.
All right, a little different today. Short but sweet. I have two quotes that I just love. And I look at these frequently at the house. And the first one's by Winston Churchill, and he says, we make a living by what we get, but we make a life by what we give. And Muhammad Ali, I love this. Service to others is the rent you pay for your room here on earth. So for the last 7 years, a doc served as chief medical officer and has provided that type of service and leadership and countless hours and direction, and that needs to be recognized. And so, Dr. Kirk, thank you very, very much from all of us. There was a banner. They tried to print Team Butt Hut. I don't know. Whatever. So, in speaking with your dear sweet wife, apparently you needed some biking stuff. Anyway, that'll come in your email tomorrow. Not today. I didn't want you to get it.
Is it spandex?
Early. The worry is it might be, but I don't know. Anyway, just know you're appreciated, big fella. Thank you. Okay. Everybody, thank you. No, you're welcome to stay.
Can I?
Please. Oh gosh, yeah.
Hey, it's been nothing other than an honor and a privilege to help serve the Star Valley Health in this capacity. And I really do appreciate the space that you guys gave me to try to figure my way through this and make mistakes and kind of help and understand that, hopefully understand that my heart is always in the right place to try to make this a better place for not just the provider, but everyone. So I do appreciate the opportunity.
We've come a long ways from the days I remember being on the same basketball court. That was 40 years ago at least, so. You're a good man. What's that? Yeah, he finally went bicycling his basketball and Star Valley's box. Anyway, thanks for your service. Is that your whole report? Okay.
Smart guy.
We'll move on. Consent agenda, does anybody have anything they want to speak directly to in the consent agenda? Questions, comments? And I guess I'm waiting for a motion.
Make a motion to approve the consent agenda as written.
We got a second?
Second.
Which one was it?
Mindy.
Mindy, second. Thank you, Mindy. Any further discussion on the consent agenda? Sure, we'll probably hear a little bit from the finance committee also and quality and the other items. Having nothing else to change, all those in favor?
Aye.
Any opposed? Don't hear any, so motion passes. Sure, I know where I'm at. I don't see any unfinished business, so we're into new business, report from our finance and construction committee. I believe that's gonna be Jeff this
Yes.
time.
Yep. Thank you, Mr. Chairman. The Finance Construction Subcommittee meeting was held on Monday, April 20th. And in this meeting, management presented the financial results of the statements of position through the month ending March 31st of 2026. I've just made some notes of some of the more significant items just to review with you all together. Total net revenue improved in March relative to February as the organization saw general improvements in revenue generating activities such as admissions, ED visits, inpatient and outpatient surgeries, and radiology. Revenues for the month of March as a percentage of plan was better than what the year-to-date revenue as a percentage of plan was, and so that was also a general improvement. EBITDA and net income for the month of March were both better than February and also better than planned for the month of March. One of the biggest contributing factors was the result of the management decision to reduce the employer match on retirement contributions. Making this decision resulted in a one-time reduction of $600,000 in salaries and wage expense once that accrual was released. Days cash on hand at March 31st was reported at 25, and management represented that it seems to be a floor, with that number not declining for the 3 weeks between the month end and the date of our finance committee meeting. I think it's worth noting that with the PACE report that was provided right before this meeting, it's projected to finish out the month at 27. So that's also, I think, worthy to note of an improvement on days cash on hand. Net patient receivables declined by approximately $650,000 out of a total $1.5 million that came about as a result of resolving some Medicare invoicing challenges on work performed by orthopedics. Management expects to receive the difference between the 1.5 and the 650,000 from secondary insurance without complications. All vendors are being paid on terms, and the CMS third-party payer settlements liability was settled in full in the month of March as well. For year-to-date ended March 31st, net revenue was $2.3 million below plan, EBITDA was $1.4 million below plan, and net loss was $2.9 million below plan. The committee expressed concern about how the financial performance could improve by fiscal year end, and management conceded that it's looking less likely that the organization will be able to address its net loss through revenues alone. When asked about how to address the expected net loss, management indicated that there are still some significant headwinds related to the portion of revenues coming from Medicare that needs to be addressed in order to return to profitability. To help with this, we had a discussion where management represented a margin impact analysis on the Medicare revenue mix that quantified shortfalls in total net revenue and its consequences on the year-to-date margin. The analysis showed a 2.7% increase in Medicare-related revenues above plan, meaning that
of the total revenues to date, there was about 4.3 million more of those revenues being attributed to Medicare than what was previously planned. At the current Medicare reimbursement rate, 2.3 million of those revenues will never be collected, explaining 2/3 of the loss that's been reported here to date. The committee also engaged in a discussion with management regarding expected performance through the fourth quarter, how it would affect fiscal year-end performance, and how management discussions regarding operating expense might impact the end-of-year performance and budget preparations for 2027. There were some adjustments to employer matching contributions toward employee retirement accounts, adjustments to merit increase accruals, and the elimination of the CMO position, and other staffing strategies are expected to bring operating expenses in line with the total net revenues through the end of that in the fourth quarter, as they finish out fiscal 2026, even with this increased revenue, increased Medicare revenue mix. If this was to be executed as planned, management expects the year-end net loss to hold at the Q3 levels and to see an improvement in days cash on hand over the same period. Management also represented that the changes that have been made thus far are a sustainable shift in the expense structure, and that we would continue to see those benefits from these changes into fiscal 2027. These changes, along with the additional staff alignment, possible employee health benefit plan restructuring, and adjustments to how EMS is funded, are all expected to address the expense side of the income statement, which, when combined with the typical growth rates in gross revenues, it's expected that there will be positive net income for the fiscal year of 2027. Management provided additional visibility to the subcommittee in regards to the current state of rural healthcare transformation grant. There's a single CapEx item that's expected to be completed in the next 60 days to replace the hot water system that's used for climate control within the facilities in Acton. And there was a proposed patient obligation discount policy that was given to the committee for feedback. The current patient obligation policy is to offer a 15% paid in full discount on balances over 500 for insured patients, and a 30% automatic administrative adjustment or discount on gross charges owed by uninsured patients. The proposed policy is to offer a 20% paid in full discount on all balances with no minimum that are owed by insured patients, while continuing the 30% administrative adjustment for uninsured patients, but also offering an additional 20% discount if those balances are also paid in full. Management demonstrated the effect that the current policy had on revenues through fiscal 2026 and what the effect would have been had the proposed policy been put in place at the beginning of the year. The results showed that there would have been lower than anticipated write-offs to bad debt. There would have been a projected increase in gross revenues as more patients utilized Star Valley Health for services performed instead of going outside the valley for their care, which also had a positive impact on the Medicare revenue mix problem. At least that would have been the case in the short term. The committee provided feedback and expressed support of the proposed plan. There's also a complete list of disbursements made for March 2026 that were presented to the subcommittee, and these, along with the minutes from our meeting, are included in the board packet that's presented, and this is my report.
Questions, Jeff, to the Finance Committee? General questions?
When are we voting on this proposed obligation to discount policy?
We're gonna,
questions on it?
as I recall, we're discussing that in executive session because it
Okay.
comes from a legal opinion.
Oh, okay,
And
So wait till
then we'll announce, then we'll have to vote in general session.
okay.
So
I can
that's-
wait till then to ask my questions.
Great,
Okay.
that's part of our executive session.
Okay.
Other items besides the policy? Okay. Moving on to quality, Abby.
As per usual, excellent numbers recording. Sadie, can you clarify? You reported for Mallory, and it looks like we're touching on Q1 through Q4 for quality improvement projects. It's not here.
I'm here.
No, you are. Is that a fact?
Correct.
Like in the first quarter, we're addressed, or like, can you tell the board how they're organizing that? Or they basically got a pull from the staff of what they need addressed, and they're just identifying that they're hitting those 4 time on a quarterly basis.
Yeah, so, well, yeah. So if you recall, one of our goals for this year is to complete a quality survey, a culture of safety survey, and from that survey, we developed 4 different PI projects, and so we are addressing them throughout the year. So there's 4 projects that we're working on, and I can go into specifics if you'd like.
That answered my question. I didn't know if this was the first set of 4 or if these were the 4 that we decided to tackle this entire year.
Yeah, the entire year.
So the point that I wanted to make was it's very interesting grabbing the information from the staff and then showing what they're doing to implement change in those areas that we've identified by the staff. So I appreciate that. If there were any questions on metrics, I'm happy to go over them, but nothing was of concern. And I would say Nolan Heiner, he brought up the point that we average about 13,000 a month in items that go out of date. That's the average, but there were this month was like 17, or the previous month was like 17,000. And just want to make you aware that he's very aware of that and concerned about that and going to do what he can to. He just thinks that number's crazy, and so he's really looking at trying to improve that for the benefit of the hospital.
Who's actually asking for input from all staff
Yeah.
members to
Yeah.
watch out for
Yeah.
that. So that was,
Yeah.
everybody's being concerned about
Thanks.
this is a cost cut.
Yeah, he didn't consider that a small amount, so I appreciated that, and I feel like he kind of felt bad about bringing up like being pessimist, but I'm like, we want to hear this kind of stuff, because if there's a way that we can help in those little ways, that's important. And then I'll read the last of my report. It was, last month's meeting, there was a comment suggesting, given the hospital's current financial situation, there may be an effect on quality in order to reduce costs, and I wanted to address that point. When this idea was brought to the Quality, Safety, and Oversight Committee, there was a strong and unified response. The committee expressed that a statement like that may stem from a misunderstanding of what quality truly means in a healthcare setting. Quality is not an added expense or a luxury. It's a foundation to safety, effective patient care. The work of QSOC is centered on ensuring that patient safety and quality of care remain at the highest possible standard, regardless of financial uncertainty. In fact, maintaining high quality care often prevents greater costs in the long run by reducing complications, improving outcomes, and strengthening trust in our system. The committee remains deeply committed to upholding these standards, even in challenging financial times. Our responsibility to patients does not change. We're dedicated to finding solutions that are both financially responsible and firmly rooted in delivering safe, high-quality care. I felt it was important to bring that perspective forward so that we can remain aligned in our understanding and priorities as a board. Additionally, to understand that we have directors in each of these departments that are dedicated to this vision for Star Valley Health. That's my report.
Anybody have any questions of Abby? Okay. Moving on, I don't think we have an ethics.
We didn't,
right?
no report this month, Mr. Chairman.
And foundation report. Mike,
I'm not here, he'll be here later.
were you in attendance? Could you maybe give us a quick overview of what was discussed? We did see the minutes.
Mr. Chairman, yes, I was in attendance at the last meeting
Thank you.
of the board of the foundation. I can report to this board that our bowling event, fundraising event that we held in March was very successful. We netted a nice amount of money that was donated to foundation through sponsorships, and that was we're really pleased with the many of our physicians and others were willing to sponsor teams, and I think a lot of our employees who were interested in bowling had an opportunity to do that and have a fun Saturday. I know the theater for the kids matinee at 10 a.m. that morning was chock full. And everybody's children, employees' children and grandchildren really had a fun time. So I think it was a really nice day. Appreciate the foundation board members who were able to attend to help, and it was a great event. Our last board meeting, we also discussed the, as you are aware, we have interviewed for a executive director position. I think last month I received some feedback from this board that I had to consider as a recommendation to you. We do have a meeting early in May of the foundation board. I will be able to share with them this board's outlook and view of how a position for the foundation executive director should be funded. And I hope to be able to present to you in the next month's board meeting the name of an executive director that the foundation will be willing to fund through foundation funding.
Would you remind me of what the board decided?
Which board?
Is it just, you're not talking about our board then? You're saying that they've decided how they ought to fund it, or we have?
No, you have decided,
We had a
last
robust
month, you
discussion.
decided you
And
were
I
not.
forgot,
going to
that's what
fund
I'm
it.
asking. What did we decide? Would you remind me?
This board, the North Lincoln County Hospital
Yes.
District Board, in last month's meeting, I received a lot of pushback about Star Valley Health funding the salary and benefits of this position. So I have gone back and spoken with our CEO about that. I will go back to the foundation board in May and seek their approval to utilize foundation funds to support that position. Then I'll come back to this board at the May 27th meeting and bring you their news.
Okay.
I feel like, as I had mentioned to you, Mr. Chairman, last week, that this board's needs to consider this is a pay me now or pay me later proposition. But I do understand the need to save on expenses as much as possible for the hospital district, and I believe the foundation board will understand that and feel like they can, at least for a period of time, fund the position and make our foundation program a very successful program. And I think that we have lots of great opportunities to do that. So,
Quick question then on that. Is it possible in that position that can be base salary plus maybe some commission on motivation to bring money into the foundation somehow? Is that possible, or would we be breaking laws if we
yes,
structured it that way?
I did do some research, and I shared that with you, Mr. Chairman. And there are ways to do that. There are certain laws that govern how a charitable foundation pays an executive director. We would have to stay within that law, but there are opportunities to have the salary stepped in a way that would be lawful. So we'll consider that as we move forward.
Yeah, as you and I talked, it seems like it's nice to keep motivation involved when we're trying to get funds. And good salesmen, if they're good, they're really good, and they do so because of that. And so at least it's been my observation. So if we can do something like that, I think presenting that to the foundation board may also be of help. So,
Mr. Chairman, I want you to know the candidate we've identified is highly motivated.
right.
So I don't think that'll be an issue at all.
Okay. Other questions from Mike and the foundation? Thanks, Mike.
Well, Mr. Chairman, if I may,
Please.
our annual golf tournament, our 25th golf tournament is coming up on June the 12th. And I would like to invite each of you to attend, be present, participate if you'd like. And if your business would be of a mind to contribute toward the foundation and help sponsorship, through sponsorship, we'd be grateful for that too. Thank you very much.
It'd take me longer during the day to get through the play, so I don't think I'd need to do that. I always count on the number of balls I lose or not lose.
We'll furnish you some, so you can have extras. Thank you.
Thank you.
Thanks. Auxiliary, I attended the auxiliary. It was a good discussion. Dr. Hauser was there. I was impressed by his presentation to the ladies about his services. I think I wrote down in my notes that he would be a great ambassador for our hospital. And I think he is anyway, but I was very impressed. So the other thing we talked about was the EMS district a little bit and what kind of cost that would be. Went through the property value formula of what it might be, and we talked to the auxiliary about that. So hopefully I didn't misdirect anybody. One of their concerns, I think, was whether it would be combined with the hospital district, and I let them know that it would be a totally separate district. So they did have some questions about billing that I didn't have any answers for. I've submitted those to Scott. And I'll just name them here for the board to know. Some of them have been my concerns over the months too. Billing, why do we receive one every 2 weeks? No balance forward on the statements, and I just happened to be looking at mine earlier this morning and realized that that really isn't there. And at least from those ladies' standpoint, they're wondering why they didn't know what the previous balance was and why it wasn't being printed. So anyway, and you have these in my email, Scott. Old invoice is still coming. And the other one was somebody had trouble with a double payment, that it wasn't seen in the system, and so their husband had already paid it, and then they paid it, and I don't remember the time frame in between. I'm sure all those things could be happening. The auxiliary's doing a great job, but we did have quite a bit of discussion. I open it up for questions, and maybe I shouldn't have, but anyway, we got some good questions. Anybody? They've got, let's see. They talk about, well, you'll be talking about marathon sometime in the foundation in the future. Oh, card party, June 18th. I'll announce that so that you know. And they're also helping with the Veterans Wall.
What's the card party?
I think they play cards.
Yeah, they have prizes and stuff.
I have no idea, having not been to one.
Is it a fundraiser? Have they done it before?
And it's a fundraiser.
At the senior center, yeah.
Be in Thane this time, 2 o'clock. Veterans Wall, they talked, I guess that's in the middle of July, if anybody wants to help with that. They had announced some times that set up a takedown. Other than that, that was the report from the auxiliary. Any questions about that? Okay. We're on to our CEO report then, Dan.
Thank you, Mr. Chair. So, Mark, you really outdid me on this one. I wanted to recognize Dr. Kirk, but thank you for bringing all these people that just to show that support for Dr. Kirk and you know, obviously Dr. Kirk and I have worked closely with each other over the last several years, and this is going to be an adjustment to the organization. It will, and but he's not dying. He's not going away. He's going to be a great physician for a lot of his patients going forward, and we're very pleased that we still have that interaction with a wonderful man, wonderful person, and a wonderful doctor. So thank you, Don. Some of the highlights that need to make mention of. We've spent a lot of time in the organization because of our concern about Medicare. We have filed the fiscal year 2025 amended cost report, and I'm pleased to report that rather than paying Medicare, we're going to receive over $1 million from Medicare for that one cost report. I want to give special recognition to Tanya and Scott and their teams. They have spent hours and hours really redoing these cost reports in a way that Bailey has directed us and give us that expertise. And it's because of these efforts that we are we're feeling good about going into the future with especially the growth of Medicare over the next several years in the Valley. And it's going to be paramount that we really become, I won't say myopic on the cost report, but it has to be a centerpiece of everything that we do. The 2024 amended cost report is in process, right? And we expect another positive result from that amendment as well. And then going forward, as we file our cost report for this fiscal year, we are letting CMS know of some of the changes that we're making to maximize reimbursement on it. I'll give you one example, and that is the ER physician time capture. That's going to have significant improvement in savings or reimbursement for the organization. The next thing I'd like to point out is, just again, this is all in writing and you can review, but for public record, I just want to highlight some of these important initiatives. Our cardiology program continues to grow. We're now maxed out with the clinic in Pinedale. With 1 day, we're going to need to move to 2 days, and so that decision has been made to move that forward. We implanted the first loop recorders at Star Valley Health recently, and next week our interventional radiologist is going to be here, be trained, start, and we're going to be able to capture those procedures at an interventional radiologist. So again, folks don't have to go outside the valley. The surgical, the spine surgical volume is it's really heading in a very positive direction, and there's opportunities to get even busier there, and we're having discussions about how we can do that. And then lastly, well, two lastlies. One is May 19th is really the date that the county commissioners are going to vote to create or not create an EMS district. So our eyes are set on that. We do have another meeting scheduled with the leaders of each of these towns a few days after that. Is that right, Mike?
Yes, on the 21st.
On the 21st, yeah. So a couple days after that, I think we'll have some clarity, more clarity on direction and what the next best steps are to address it, and then we'll report back to the board at the board meeting in May. And then secondly is the rural health transformation funds are still in a holding pattern. The latest that we received from the Department of Health is that it does appear that they may have to give on their request to put 70% of the funds into an endowment for in perpetuity to fund some of these initiatives.
You don't like a savings account?
I don't think that's going to pass muster. So,
Yeah,
any questions, or do I need to address in more detail anything that on my report before I get to the next presentation, which I think is really where I wanted to spend my time? Okay. In your board report, there is I put a slide presentation, and it starts with should SVH, so any of you that have access to the board report, should SVH reduce its charges? If so, where and by how much? Every market that I have been in my career, this is a hot topic, and it comes and it goes, and there's always concerns about the cost of healthcare and the affordability of healthcare, and especially when hospitals raise their charges. And so what I want to do is I want to make sure that there is a book of truth and some education on charges and an understanding, so that we can have a consistent message to the community a consistent message to the medical staff and to our employees, and especially to our patients. And so the three areas that I want to go through to help provide this unified approach is one, volume versus the reimbursement trade-off. Two is the understanding of pricing elasticity in healthcare. And then three, a recommended approach going forward, how to message this and how to make sure there's clarity so that folks can really understand or feel better about, well, is Star Valley Health too expensive or not too expensive? So the first thing that I want to demonstrate is that there is a mathematical equation when any business, but healthcare, when you reduce your charges or increase I'll just say reduce your charges, you have to figure out, well, how much volume would then need to replace that revenue in order to break even. And the simple mathematical equation is you take the required volume increase percentage, and how you get there is you take the price decrease percentage minus 1 minus the price decrease percentage. And so a little chart shows that, in that if you reduce charges by 5%, you need to find volume from a commercial payers by 5.3%. If you reduce it by 10%, it goes to 11.1%. 20%, 25, and 30, 42.9. So the key takeaways is if you cut prices, you need a disproportionately larger increase in volume just to stay even. And the bigger the price cut, the harder it is to break even.
So where did that form, I mean, teach me about this formula. It's not one I've seen based on statistics.
No, just math.
So explain the math to me. I guess I'm not catching it.
Okay, so
I realize the formula is math.
yeah.
And I can
But
put in
where
the
does it-
numbers and come up with the numbers, but what I'm asking is, why does that work? Why is 2 plus 2 equal 4?
Yeah, so take the required, so let's just say you wanted to reduce charges by 5%.
Yes.
Okay, that's your numerator. Then 1 minus the 5%,
That
that gives you
Divided.
0.95.
Yes.
So you take the 5% minus divided by the 0.95 gives you
Right.
the required volume that you need in order to replace it.
Why is that true? I mean, what I'm missing here is why does that work?
So let me go to the next slide and I'll show you.
Okay.
Okay.
You understand my
No,
question?
I do. Okay, so what you're.
Does it really work?
Yeah, okay. So let's
That's
do
true.
a commercial contract. So the next slide.
Okay.
How would a charge reduction impact Star Valley Health's revenue? Okay, again, the question we're trying to answer is, if you reduce charges, you're going to have lower revenue for the organization.
Correct.
How do you make that revenue up? And you make that up by additional volume. Because the assumption is that if I reduce charges, people will come to Star Valley Health.
More people will come.
Okay,
Sure.
so that's the assumption. Now what I'm doing is I'm challenging that assumption.
Do banks work that way?
Well, let's hear this out.
All right, so if you have a current charge of $10,000, that equals a $6,000 payment if our contracts are based off of a percentage of charges, which our 4 major payers are. Okay, so we charge $10,000, we get $6,000 reimbursement. Let's say that we reduce the charges by 20%. So our charges are now $8,000. So now our reimbursement goes to $4,800, a difference of $1,200. Okay. So how much volume do you need in order to make up that $1,200? That's where the formula comes in. And what it says is at 20% reduction, you need a 25% increase for that to make up in that area of volume that 1,200.
That's assuming a commercial contract, though, right?
Yeah. So this only pertains to commercial. This is where the price sensitivity is the most. The price sensitivity isn't with Medicare because we all know, based off of our as a critical access hospital, it's based off of cost reimbursement.
You're pointing at me because I'm the only Medicare.
No, there's probably, some other people might be close.
I don't think anybody
We're all
is
gonna be-
anyway.
All right, so that is the important thing that I want the board to understand is you can make a decision to reduce charges, but there is a cause and effect to your revenue, and you have to really feel very confident that you're going to get that volume back to make up that. Now, the other way that you can manage this is you reduce your costs by that same amount. So those are the management decisions that we're challenged with on a daily basis with the hospital. Okay, so now.
So I'm still in my question, I guess. The $1,200 that we've got to recover, how does that quantify as a 25% more patients? I'm still not putting the dots together, I guess, here.
Well, so
I understand the math. We got to make up $1,200 because we gave a 20% reduction, right?
yeah, so we can by calculator.
And
1,200
then
divided by
we're
the
saying,
4,800 that he's got there is 25%.
what's that?
1,200 divided by 48.
Oh, that's the 25%.
Yeah.
Okay.
If you did a 20% reduction cost, it would be 25% more.
I'll have to think about it while what's going on.
He could have said if we wanted to reduce charges by 5%, we could.
Sure, no, he did use the 20, I
7%
understand that.
commercial.
Yeah, 5% would be 5.3%.
The 20,
Right.
5%
do the
volume.
25.
It's just.
So, can I ask a question? Sure, I think that's.
Oh, I was thinking, didn't you see the steam coming out of my head?
I just wanted to approach it appropriately. If you care to ask a question.
Please, go ahead.
So,
Thank you.
and I understand that, it's cost-based on the
Medicare
side, right? But do we know for sure that there's no impact, and I guess this is my lack of understanding of the cost-based structure, but to us reducing charges on the commercial side, is there any impact to us on the Medicare side?
No, from a Medicare patient standpoint, there is, okay, so there's the hospital reimbursement and there's the patient, right? So we reduce charges for a Medicare patient, no change to their annual co-pays, deductibles, what they owe. It's pretty fixed. That's the patient.
But what we're getting reimbursed for.
So then we do deal with the cost to charge ratio on the cost report.
Right.
But when it's all said and done, it has nothing to do with charges, it has everything to do with our costs and what's reported on that, on that cost report.
But how does it affect, like, when we're talking about getting reimbursed from Medicare?
Doesn't change the reimbursement.
Doesn't change,
It'll be less.
It does, this is only for commercial insurances. Because remember, the methodology of reimbursement for Medicare is just wacko.
No, I understand that. I just, I think that there's enough variables into it that I think we just want to make sure that when we make a move, that there isn't additional
Ramifications.
ramifications.
Yeah.
So you're basically, if you reduce charges, then if I'm a Medicare patient come in, I'm going to have that same 20% for that procedure, right? And so Medicare is going to reimburse the hospital based on the same formulas.
No.
Are you going to get less?
We're going to get,
Whatever cost pluses.
we're going to get the cost
That's right.
associated with what
Has
we.
nothing to do with.
Has nothing to do with our charges, has nothing to do, now, we do have to report our charges. There are cost charge ratios that go into the cost report, but when it all comes down to the reimbursement of Medicare, it is purely the costs associated
Okay.
with that department for those Medicare patients.
That makes sense. I just, forgive my skepticism.
No, that's all right.
So,
No, again, this is why I want to field any type of skepticism so that there is a complete understanding, because you guys are out in the public having to answer questions to all this, right? And so am I, and so is the management team, and so are the employees. There has to be some education on this. If we don't do the education on this, there's crazy narratives that people can go to. Okay? So, are we good to move on? Good to move on?
Good.
Okay. So, what I want to do is I want to reframe the concern from high charges to allowed amounts. Every hospital, I don't know about ambulatory surgery centers. I don't think that they fall under the same rules. Every hospital reports their charges, but guess what else they have to report? They have to report the commercial average discount that they use to get to an allowed amount for that facility. So an allowed amount is the maximum your insurance company agrees to pay for a medical service. The insurance payment and the patient's responsibility, their deductible and co-insurance, are based on the allowed amount. Each facility has a different allowed amount because each facility has different negotiated managed care contracts. So if we negotiate very favorable managed care contracts, is that good for the facility? You would think yes. But could it increase the allowed amount to our patients? The answer is yes, because our contracts are based off of percent of charges. So where we have to focus the apples to apples comparison to other facilities is helping people understand what our allowed amount is so that they can take that and compare it to St. John's, compare it to Irmac, compare it to some places down in Utah. That allowed amount is all that the insurance is going to pay and the patient is going to pay. That's all that the facility is going to get. It doesn't matter if I charge $100,000 or $10,000, that allowed amount comes down to the negotiated rates of the contracts for each of those facilities.
And we've talked about this before, and I understand that concept. But when patients are deciding where to go for their procedure, I don't think, I mean, and I don't know how we educate that. I mean, that's a one-by-one. That's a tough education in my mind, because I think they must be seeing charges on the website somewhere, or they've gone in and got an estimate, or called in and got an estimate.
Well, this is where we've shot ourselves in the foot. Our biggest problem is the education on the allowed amount, and then what we're telling our patients when we give them a good faith estimate. So I'll get to that.
Okay.
What we're going to have to change in order for this to be clear in the
You
minds of the
understand
patient. I totally
my
do.
concept, I think.
Yep.
And the only way I've done this in the past, I haven't done it recently, in the past, was to call and get an estimate. And in those days, I didn't give very many estimates. Well, we're not sure, I'll pick that house.
Well, so price transparency, if you haven't been, if you've been paying attention to the Trump administration and the state legislator, the federal legislation, price transparency for hospitals is going to get more and more and more specific. And the biggest thing that is going to come of this is this allowed amount. Right now, I said it's a blended average rate for commercial insurance. Now, I think in the future, it's going to be, what is your this is where the rub is, right? We're now going to have to disclose our negotiated contract rate for Blue Cross Blue Shield. And we're going to have to disclose our negotiated contract rate for Aetna.
Yeah, disclose it to
The public. That used to be proprietary information. And
This is the new administration is headed that way.
that's where we think it's going to head.
No, it's gone that way. It's in effect starting July 1.
Okay. So what's confusing to everybody is, well, who do you have? Do you have Blue Cross? Or do you have Cigna? Or do you have United Healthcare? Or do you have Aetna? Oh, and then what's the negotiated rate at Star Valley Health? Well, that's different than the negotiated rate at St. John's, or that's a different negotiated rate. Well, hold on, how do I make a decision here, and how do I compare apples to apples? When we do an analysis on charges, and this is how we've done it in the past, is we've looked at every facility's charges for a certain CPT code. And guess where the facilities are with their charges? All over the board. There are some that are low, there are some that are high. We're sometimes high, we're sometimes low, we're right in the middle. The facilities throughout the country are just all over the board with their charges. So what really matters to patients, to facilities, is this concept of allowed amount. And it is being disclosed on our website and every other facility's website, because that is where the legislation is going.
Okay, so currently, help me understand then. So if a patient comes to our hospital, whether they get an estimate or they go on to our charges, they're getting a number for a procedure, whatever they're gonna do. Let's say it's a knee, for the heck of it. They have an amount, here's what it's gonna be at Star Valley Hospital or Health. And then they go price it in other places. And surgery centers, we know, are always gonna be less.
Yes.
Because they have much less overhead.
Well, no, they have less negotiated contracts. Their contract reimbursement is so much lower than a hospital that their allowed amount is going to be lower.
Okay, so what you're telling me is that even though another organization may be less expensive than ours for the exact same procedure, out of pocket for both the insurance company and the patient could be less if they came to us than if they went to the competitor. Did I state that?
Say it one more time so I make sure that I answer it correctly.
I'm not sure I can state it. Okay, so we've got, what you're telling me is that the amount paid by both the insurance company and the patient
is the allowed amount.
Okay, could be less at Star Valley Health than the one they chose that appeared to be less retail charge because of those contracts.
That's exactly right. Or we could be more.
Well, and yeah, it could go either way.
Go either way.
You're telling me you can't look at retail prices and decide whether we're more expensive or not. But I gotta believe that 95% of the population is still looking at a good faith estimate somewhere.
Well, the problem is our good faith estimates have just been charges.
It's based on charges, not the allowed amount.
I agree.
So you come and get a CPAP for me, and on my invoice, it says, I'm gonna charge you $5,000. You go, golly, but you got UMR through the hospital. UMR's only gonna cut me a check for $600, go away. I can't come after you for the rest, I'm contracted.
Right.
To accept.
That's the allowed amount.
That's the allowed amount.
And I understand
So
that.
that's, yes.
So whether he charges 10,000, 7,500, 5,000, his number is 600.
That's it.
And I've understood this in our conversations in the past, that it all has to do with the insurance contract. That each individual or each company and each provider has, right? But if people are going elsewhere, they're comparing something to motivate them to go somewhere else.
And charges.
And then what I'm
And it's
saying
charges,
is,
right?
what I'm saying is we have been giving them the wrong information or not enough information.
Well, why don't we just cut all our charges to zero?
I would love to do that in healthcare. If somebody would allow us in this federal system of healthcare to get rid of charges, I would be all in favor. But you know what? We can't.
Well, but we can broadcast them at whatever we want. You're telling me.
But the system is based off of, the whole healthcare system has always, for decades and decades, been based off of this charge system.
I understand, but
And so
what you're telling me is those aren't facts that I can rely on to compare against.
you're absolutely correct. Go ahead.
Our estimates, to the extent we know the insurance companies that they're dealing with, do try to get to that allowed amount.
Yeah,
If we know.
yeah, I wanted to say that.
If they don't
That's
offer
a
it, or they just
project
want,
that we've been working
if
on.
it's cash.
Within $400.
Huh?
Within $400.
Yeah.
Ish.
if we know they're,
Yeah.
the insurance
That,
company.
that's one thing I'm hearing, I'm like, I'm pretty sure I think some of the assessments we're doing were a little bit crazy, but I just wanted to make the point, they have taken individual people's insurance. If they've already had another procedure, have we already met the deductible, are we just into the co-insurance? All of that's supposedly sorted out, which is great.
Yeah, good. I think Clint had a hand up, and then I got Jeff, I think.
So to add another layer of mystery, I don't know if you guys, so like with us, there's a lot of stuff on Blue Cross. The main stuff that we bill all the time, we know the reimbursement. But if it's some kind of novel, well, their price structure is proprietary. They won't even tell us an in-network provider. You just have to bill it and find out. Do you guys deal with that garbage?
Yeah.
So there's another layer of, you know, on something novel that they don't do all the time. Well, what's my cost gonna be? You're like, I don't know, because the morons won't tell us. what they're
Okay,
gonna
so to your point.
They literally won't do it.
To your point, what is being left out in this price transparency is the insurance companies.
Oh.
So the hospital organizations throughout the country are saying, you want us to reveal our prices?
They
Well,
need to be.
They need to be part of this as well. If we're really going to solve this, hey, how much is it gonna cost me for my health care?
How are you supposed to get an answer if they don't tell you this is what we're gonna read?
That's-
You have no idea what to tell.
So
them.
that is,
All right,
I truly believe that is part two to this whole healthcare dilemma in the United States.
And what we found is on our end, some of it's so low that it's like, no, we won't bill that to your insurance. We did, in fact, I can't bill it to anyone because Blue Cross has said, yes, we'll pay you $25 for something that you normally charge $500 for. So I should have to accept that. So guess what? I just pull it out of my inventory. I don't do that anymore. I'm sorry to the people that need it, that have insurance that cover. I can't do it because of that.
Jeff had a question.
Or I'm gonna breach a contract.
Well,
You're next.
maybe a little higher level, just making sure I kind of understand what some of the consequences of this all, I get it from a price transparency, I think, for a consumer. Do you see this creating a situation where, I mean, we had a situation before when you've got one contractor price wanting the same value that Blue Cross gets, and you see a scenario where more and more
Yes.
contracted insurance providers are going to use this data
I do.
to put some pressure.
I-
And then,
I think there's going to be, sorry, finish your question.
and then just the second question, so I've got another one, so you can answer that
Okay,
first. if you want.
so with the pricing transparency that's being put on hospitals, again, I don't know, I gotta do more research on whether or not ambulatory freestanding imaging centers and surgery centers, because they're going to win the cost argument any day of the week. But from a hospital perspective, if we are transparent with our allowed rate and amount by contract, the insurance companies are going to be knocking on our door saying, why aren't you giving us this rate? And we're going to have some justifiable reasons to say, well, there is kind of a favored nations. I mean, Blue Cross Blue Shield is our biggest customer, right? And so they do get a discount. And but we're going to have to work through that because I do believe there's going to be pressure on hospitals to make them the same.
Which is maybe connected to my next question. Right now, the Blue Crosses, they know what the allowable amounts are for Star Valley Health versus another provider.
Uh-huh.
But they're not really motivated to really disclose that as much because of this proprietary pricing.
Well, they are motivated to let the patients know where they can get, where the lowest allowed amount is to get that done.
That's where I was going, is if now I know as a customer,
But yeah,
the insurance companies putting pressure or not even saying you can't even go to Star Valley Health because the allowable amount is higher. And now you know and we know, and so now you have to.
they can't say that, but what they're going to do is strongly incentivize the patient to go to the lowest cost setting.
What's the incentive?
The incentive,
Reimbursement.
so the incentive is one, the insurance company doesn't have to pay that facility as much as the higher cost, or the higher
Yeah,
contracted
but
rate.
they're not gonna pass it down to me.
But you
get the
You might have, because of that contracted rate at a low, which produces a lower
My portion.
allowable, your portion is going to be lower.
But that already exists.
It does, but people don't know about it. So insurance companies are trying to play the same transparency issue with, well, I want to get an MRI. What are my options for an MRI? Well, if you go to this facility, this is our lowest contracted allowed amount, and it's going to be the least amount out of your pocket. And by the way, if you go there, we're not going to pay as much either. So they're highly incentivized. Okay, moving on. Okay, here we go.
Any other questions right now?
All right, now I want to introduce the concept of elasticity in healthcare, okay? Instead of blunt cuts, you have to choose targeted charge adjustments on allowed amounts, plus you have to ask yourself the question, is it really going to influence patient behavior? There are, through, again, empirical data studies, state that certain parts of the hospital are more elastic and certain parts of the hospital are less elastic when it comes to influencing patient behavior based off of prices. So you go to the next one. So let me give you a definition of elastic demand. Patients do change their behavior when prices differ. So if it's elastic, hey, you lower your price, I'm going there. You up your price, I'm going to hold back. If it's inelastic, it's basically patients don't change their behavior much, even if prices are higher. So this is obviously you learn this in your economics 101 class, but the study that is probably the most predominant in the industry is a 2017 study on this exact topic. Is what is the demand elasticities of service type in a hospital? And so they focused on spot prices or allowed amounts consumer use when deciding how much to spend on each type of healthcare service, outpatient, inpatient, emergency, etc. They included people enrolled in all the commercial payers, HMO, POS, PPO, comprehensive, consumer-driven health plans, and high-deductible health plans. They looked at 73 employers with 732 plans on 14.2 million individual years. So a huge sample. And
What do you mean by individual years?
Individual years, like how long they were participating on the plan. Okay. Included all individuals aged 0 to 64, so this does not include Medicare. The mean age was 34.1 years in the study. It came from the IBM Truven Health Market Scan commercial claims and encounter database, and this is now a predictive model for hospitals and insurance companies that they use based off of this study. I'm not going to be able to go into all of the statistical ways that they came to their conclusions, so I'll just share with you what they.
We'll waive that.
Yeah, we'll waive that, okay? So, but I did provide the source. If you do want to go into the detail of the study, it's in the Journal of Health Economics, PMC 2018, there's the website. Findings. Here is the elasticity numbers for each of these services provided in the hospital based off of the study.
What's more elastic?
Okay.
The smaller
the negative number, that is inelastic. The higher the negative number, that is more elastic. Okay. If it's a positive number, it is extraordinarily inelastic. Okay.
Okay.
So here's the interpretation. A 1% increase in the spot price or the allowed amount leads to so you look at the all spending in the hospital had a negative 0.44 at the very bottom of that chart. So every 1% increase in price leads to a 0.44 or a little over 0.4% decrease in demand. This again is trying to measure patient behavior based off of price fluctuations for that spot price. So a 0.44% decrease in demand or volume. Conversely, a 1% decrease in spot price leads to a 0.44% increase in demand. Now notice that the only one on here that's positive is surgery, okay? What this means is demand is essentially insensitive to price and may even increase slightly as prices rise, likely due to brand, referrals, or perceived quality. And what they've learned is that the higher the complex the surgery, the more inelastic it is, because that surgeon is going to be able to solve my problem and I'm willing to pay anything for it. Make sense? Okay. The other inelastic services in a hospital are what? Emergency services. Nobody's going to be shopping prices or questioning about emergency services. Our ICU, sometimes even the inpatient. Inpatient does have an elasticity, and some people do keep track of that, but
It's highly dependent on how much time you have to make it.
exactly. So the more elective it is, so surgeries that can be done in an ambulatory surgery center, that starts to move more towards the elastic side. Because now I have a price comparison between doing it in a hospital and doing it at a surgery center, which most likely is a lower cost setting. The other takeaways from this interpretation is that they do vary significantly by service line. Outpatient, imaging, and lab are some of the most price sensitive, and emergency and complex care are the least sensitive. So now connect this study to what I just shared with you about volume and price increase. So how does it work within the analysis? So if all spending in a hospital has an elasticity of 0.44, if you do a 10% price cut, you should expect overall a 4.4% volume increase based off of patient behavior from these millions of years of studies. Now, we did the math. I showed you the equation. You need 11.1% commercial volume increase to break even. So what I'm trying to point out to the board is, as we make decisions about increasing prices, decreasing prices, you can decrease them, and you are for sure going to take a revenue hit. What you don't know is, and you can make all the guesses in the world, but I'm just trying to use data to show what is the likelihood of that volume returning if you do make a price decrease. And the secret isn't in charges, because I just showed you that charges can be all over the board, and they mean nothing when it comes to a decision for a patient unless we just scare them away, which we have done. It comes down to that allowed amount. So that's the next logical step that I want to take the board, is this discussion about how to change the narrative and the education and the discussion about the allowed amount. Here's a recommendation. We need to segment our services into high, medium, and low elasticity. And we already know where they're going to land, even based off of this study. Only deploy pricing changes in the high segment and selectively in the medium segment. Doesn't make sense to do pricing changes in anything that has no is inelastic. Don't just compare, identify where we're actually losing commercial volume specifically due to the allowed amount. Anytime that there is a patient, if we hear of somebody that says, you know what, I compared prices on the allowed amount between somebody in Idaho, Jackson, Utah, we got to be all over whether or not that is something that we need to look at to adjust the allowed amount, not necessarily the charges.
How can they compare that today?
Well,
where is that information for me to even compare?
So let's just take, for example, a commercial insurance company. Here's your options for an MRI. I have an app that says, I want to get an MRI. Here's my zip code. Here's all the areas that Cigna has a contract with as a provider. And it says, go to the freestanding imaging center in Jackson Hole or the freestanding imaging center down in Evanston.
So first of all, I need to understand, so what you're saying is there are apps that people are using, that the insurance companies have put together to show where to, if you have that particular insurance company, where you ought to go?
Yes,
And people are looking at these.
yes.
Obviously, I was unaware of that,
Yeah, they exist.
but I'm also of an age I don't need to compare.
Do you know what, like, percentage of customers are looking at that kind of thing?
I don't know that.
I think it's more likely that, friends had a procedure, and procedure had their successor, whatever, out there to say something like, oh, I'm like, oh, I got my shoulders on in such and such. I think that happens.
That's another source.
Yeah. I mean,
It's word of mouth.
Thinking in a time community like this, I have to.
Word of mouth. All I'm saying is there's,
Okay, so insurance companies really are trying to direct their customers
without question,
where they
because
ought to get their services.
Because here's what the pressures that the insurance companies have is that they're going to the employers every single year with double digit saying, hey, you want to continue with our plan? You're going to need to fork over an additional 15% from what you paid last year. Well, we can't afford 15%. Guess what? We're just going to pass this off to the employees. And this has been going on for years and years and years, so that over the last 20 years, it's getting to the point where we're really at a tipping point.
And just anecdotally, if it's not the insurance company that's steering these patients.
Now the employers are.
The employers
The employers are
considering
now.
it.
Because they've received information. I mean, this is a whole new
The
concept to me.
employers can't absorb the cost.
I have never had an insurance company suggest where I should go for my health care, ever, in all my life.
Well, you
I've
have
never had
through step drug therapy, that's one way.
step drug, what's that?
You have a condition and the name brand one is the more expensive one, and they say, well, you have to start here first.
You have to use this one instead of this one because we're only gonna pay for this one, not the more expensive.
And
Okay,
and that has to
I
be-
understand what
Yeah,
you're
next year,
saying. I haven't
this year, your
experienced
doctor's
it.
like, I
Yeah.
want you on this,
Yeah.
and your insurance is like,
No.
no, fine.
So insurance companies have really directed
Yeah.
people where to,
But they steer.
I mean, have you had that experience? I have never had this experience.
I've never had
That's
the
why I'm
insurance,
asking.
I've never had the insurance company tell me that I need to go to this facility for a scan. But I can see that being a feature, which is why I was asking the question.
Yeah, I can
Because
see.
as an employer, I'm prepared to start asking my employees to go to a certain facility for certain.
I'm gonna go on ChatGPT now and decide those things, I guess. But anyway, Trevor, so
Like on our own Star Valley Health insurance app, we use UMR as our third-party administrator. We're self-insured, but we use them as our third-party administrator. If you go on there and you try to find a place to go find imaging, Star Valley Health does not even show up. And so it's not that, it's just that the health is not putting the higher price places on their insurance, and so.
they're not advertising for where they gotta pay more.
Yeah.
And I understand this concept. I just have never experienced, never heard about it, even from my kids. Go ahead, Clint.
So, let me see if I get this right. So on this example here, you got your MRIs, right? With this, Starley Health or Max St. John.
You're not gonna steal my thunder yet, are you?
So you're,
I haven't gotten to that slide yet.
okay, I thought,
Let me finish up the recommended approach,
yes.
and then I'll get to it.
Go ahead.
So, you talk about number 3.
Okay.
Just compare charges.
Okay, so,
I
don't,
don't know how you get people not to just compare charges.
well, that's what we're
That's
gonna.
where I'm bogging down.
This is what we're gonna have to do. If people are, if we're going to, we're never going to win this discussion if we just stay in the charge realm. That's never. That's number one. So what we have to do is to, as an organization, our employees have to be super intelligent about this. I mean, just everybody involved with healthcare, we have got to be super intelligent about this because we're the ones interacting with the community to help them understand. And I tell you, most healthcare folks don't even understand this concept. I am quite confident, I'll buy you a milkshake, that if I would be surprised if more than 75% of our employees understand this concept. I mean, I'd be shocked.
I won't take the bet, but I like the bet.
You like the bet?
That's what I bet on. It's not.
All right, so don't just compare charges, rather compare SVH's net allowed amounts versus the competitors' allowed amounts. Everything is being disclosed on the allowed amounts. So we have to do that analysis. This is the patient's out-of-pocket difference. If SVH's allowed amount is not competitive, you reduce charges selectively by procedure after modeling net revenue impact, expected volume lift, using elasticity and in some cases anecdotal information, and then the contribution margin impact. Next, you got to consider non-pricing levers. If we lower price but remain hard to access, we won't regain volume. In other words, you can reduce charges, you can give a discount, but if it is difficult to see a doctor, or if it is difficult to actually get the image done quickly, you're going to lose that business anyways. So there's all sorts of things that we have got to make sure that if we're going to do it, that volume is going to come through the door. That's all I'm saying. Okay, next.
Well, let me, how do we compare net allowed amounts? You just told me, the insurance companies don't provide that information.
So right.
So how do I?
No, it's not the insurance companies. The hospitals are going to have it.
We provide mandated to.
Well, we're mandated now, but right now it is just a blended number. So we have contract, we have.
You don't know what St. John's is.
We do. We do.
Why? How?
Because they have to disclose it right now
Where do they disclose it?
on their website.
Oh,
Front page of every hospital has to have it on the very front page. At the bottom, it's called a machine readable file. It's the same format, everybody does it. That's where we get our information.
So there's their blended amount, or there's the
Yes.
individual?
That's all we have right now. But where it's going to go July 1 is probably, is it?
Yeah.
It's going to go by payer.
It's going to break them out.
I think it's going to break them out. So July, and I want to wait and see how quickly hospitals actually adopt.
I can't imagine they're going to be rushing to the door like, hey, what's this?
You know, but there's going to come, there are some policemen out there that there's penalties that if you don't comply. I'm just wondering how quickly we're going to be able to see that information.
How elastic is it?
Well, it depends on the service.
Yeah, if I may, we employ a firm to keep this compliant with CMS. This is all CMS guidelines, right? So CMS's guidelines, they don't play around. And right, they've given us several years of, okay, get up to speed here, and then we're marching now. If you don't comply, there is very steep penalties per day today. If your machine readable file is not in the right shape, it's not accurate. Today, it's $100,000 plus a week or something, right around that.
Who's checking it? Are they actually checking on every website?
Yeah, I mean, on the conferences we've been to, yeah, there's breakouts on how to be compliant on your machine readable file. The next wave here, this coming year, we're working with Turquoise right now to make sure, and they're working with us to make sure that
Does everybody know who Turquoise is?
They're just a third party.
Okay, so explain who Turquoise is.
They're a third party whose expertise is compliance with CMS transparency laws. There's other firms that do it, but they've been working with us now for over 2 years. As these, you've got into compliance. Now it's time to. There's no more Mr. Night Guys. No more waiting period. And it's scary the amount of. If you are flagrantly disregarding being compliant, it's a showstopper. Literally. But Turquoise right now this week even has said, okay, we need all your data. Sarah provided it yesterday actually, so that they can make sure that our file come July 1 is perfect. So it's not. There's no more waiting or we'll give you some time to get up to speed.
You can drag our feet till we see others do it.
No, we're not taking any risk. Not even close.
They're lenient. They have been if you've made an effort. But if there's no evidence of even an effort made, they're ruthless.
So, okay, does that make sense? So it's not coming
So
from,
the information is really out there, but I can't believe, well, I can now. I gotta ask some questions around my neighborhood, I guess. That, find out people are actually they're comparing the right amounts, or they know where those amounts are, right?
well, I am very concerned that we are not even close to helping the patients clearly understand what the price comparisons, and we probably lost some business from that. So, okay, so let me wrap this up, and I'll get to this proposed recommended approach. We need to pilot before scaling. So rather than just doing a blitz of, hey, we're just going to reduce these charges and appease people for whatever reason, we've got to pick the most elastic service lines. We've got to track the volume changes, payer mix shifts, competitor responses. We want to be very measured in how we do this. Now, this is so vitally important to the success, financial success of the organization, that we have to do this right. It is very, there's regulatory issues and there are significant financial issues, because if the volume doesn't return, the only lever that we can pull is expense reduction. And who wants to take that gamble?
You know, what you're telling me is that it's easier, it will be easier to cut expenses than it will be to educate.
No, I'm not saying that at all.
Well, that's what I'm telling you.
I'm saying well, we're gonna have to cut expenses anyways, right?
Well,
Or the
I hope
profit.
so, yes.
So, but what I'm saying is, even if it takes 10 years to educate, we have got to do this for our community members.
Well, if it's out on the websites and findable, then I would assume people are looking at that, but
Marlo,
yes.
yeah. I'm getting my kind words. You're giving the general public way too much credit for understanding insurance.
Not that they're dumb.
They're,
It's insurance is crap.
when it comes to
Yeah, like,
insurance,
clarify that.
when it comes to
That's,
insurance, they're dumber than a box of
Yeah.
hammers.
Yeah.
Trust me. You're gonna have 5% of the people that they get it. I mean, they know all these terms and how they apply. The rest, not a chance. Not a chance. 13 years of dealing with it, 0% chance. So drop that notion. It just doesn't work. So yes, we have to start educating. Hard,
You think we
fast,
can?
absolutely.
I think we can do it. I think we can do it one person at a time,
Absolutely.
one transaction at a time.
Yeah.
People just don't pay attention when their insurance company tells them where they have to go get service.
Well, yeah, I agree. If that is occurring,
Well, I don't know, but it is occurring on a large scale, but it's gonna be,
well, that's what I'm hearing today, but I, not that I'm an electronic genius at all, but every once in a while I run into things. And I would have thought I'd have heard of this, because I have members of my family that love things that are free. We bought it, we gotta buy it if it's free, or if it's at a discount, let's go buy it. So, I can't believe in health insurance that I haven't seen something like this, so I'm just shocked, I guess, is that it's a whole new concept. And I've understood this, we've talked about this before, and I realize that, but I still do, I guess today what I'm understanding is it is actually out there and you can compare, right? I am still, unlike Clint, I'm afraid, I don't think people are comparing the right numbers there.
No.
If I may, just one other thing you can compare, or we look very positively, is the standard negotiated cash price for any CPT code. If you compare that number against our regional friends, we're number one or number two cheapest.
What that is, the
That's,
standard.
that's if you go and say, if I want to pay cash.
Okay, if I walk in and say, I need this
Or-
procedure,
Yeah,
I'm willing
or
to
my
pay
course.
cash, what's my number?
Right, and
Okay.
it's based off the allowable. Basically, it says, so it assumes that if you're at the beginning of your plan year and you've got to pay most of a charge, right? It says, okay, you take that allowable, less, but a discount for a paid in full discount, let's say. And this is your standard or average. It's called the standard average cash amount due on that charge. We're right in one or two lowest price. Because many or most of our largest volume charges. Because we give a hefty cash pay discount, paid in full discount. And we're gonna propose to give it even more, and that makes us more competitive. You see, we don't get down to that level, like Dan was saying, you're not comparing, like, what is the lowest price? And a lot of times, I believe that that's what you're given on an estimate, what cash price estimate could be.
All right, so here is the big, number 7 is the takeaway that I want the board to latch onto. Implement and communicate discounts on net allowed amounts. Change our good faith estimates to focus on net allowed amounts and not charges. Include pay in full discounts on the estimate. Okay, so where we're going to earn back the business, or where we're going to help people to think twice about leaving, or the price sensitivity is this area. I'm telling you, the charges it is a losing proposition from the get-go. It is on this allowed amount that we have an apples to apples comparison with almost every other provider except, I think, the freestanding centers. Okay.
And allow discounts for Medicare patients?
What's that?
And allow discounts for
You're allowed
Medicare patients?
to.
Why would we?
Well, so we're gonna,
We're
that's,
not getting enough as it is.
yeah, no,
So I'm wondering, but that sounds like a little discrimination.
no, if a Medicare patient wants to pay in full,
On their,
Well, sure.
they have
We're
no
not gonna turn
insurance.
it down.
yeah, if they want to pay in full at the time of, or before service, or, this is what we're gonna discuss in executive session.
Yeah, yeah.
But I think this is important to understand before we have the discussion about the policy.
But I'm thinking right, I mean, we get nothing by discounting Medicare. My side of it, the patient side of it. We're already getting not enough, now we're gonna get less.
No,
Is that right?
No, what I want you to know is that even with Medicare patients sometimes don't pay their deductibles.
Okay.
And so what we're after is
Those are non-payment.
we're trying to reduce bad debt as best we can, because if you get it at the time of service or before, but if you don't, the likelihood of you getting that down the road, and that's what Star Valley Health's problem was several years ago, right? We're trying to change all that. Okay,
Go ahead.
okay, so that's number 7 is the big takeaway. Now, here's the example for Clint. 7214, so the columns above are SVH, Ermac, St. John's, Bear Lake, median. We can include other facilities, but we just, for purposes of driving home the point, here are 4 facilities with a median. Here are the charges. Now, on this particular example, the charges are somewhat similar in that 2,000 range. But guess who's number 1?
Number one, most expensive or cheapest?
Well, right now,
Gross
if you
list
look at
charge.
the gross list charge, who do you not want to go to?
So
Star Valley Health. We're losing business.
this is coded, whatever those codes.
Yeah, if you're going to get a MRI lumbar spine without contrast, that is the CPT code,
CPT code.
C72148, and the charge associated with that CPT code for Star Valley Health is $2,882.
that is our largest volume MRA code.
Okay, so that's my question right there.
Yep.
So let me come in here. Okay, so that 2882. Is the reason that that's listed is because that's your highest reimbursable due to an insurance. You have an insurance contract that pays you $28.82. That's why you have to have it that high. Then why do we have it $28.82?
Because over time, so there have been some pricing adjustments for whatever, I don't know all the reasons why that number is where it is. But every facility is adjusting their charge master every single year, including us. Now, some may not have increased their charges on that particular CPT code, but we did.
Okay, so what's the benefit? What is the benefit?
There's no
of
benefit.
increasing that charge.
As long as it
It
is,
seems detrimental.
well, okay, so the reason is that we still have a percentage charge contract with the insurance companies.
There you go. Okay, that's what I was looking for.
Does that make sense?
Yeah.
Okay. All right. So right now, don't go to Star Valley Health for this MRI. Don't want to go there. Now, what we've done is we have researched how much we got onto the websites and how much are other facilities actually being paid. This is that blended rate, contracted rate. So here's your standard allowed. We are still the highest. Why are we the highest?
The charges.
Or we got a higher charge, and do we have favorable managed care contracts? Absolutely. Okay, I mean, there's going to be some facilities that are going to be jealous of our contracts, but what it doesn't do is again, this puts the patients from a deductible and co-insurance amount in a sticky situation because we have favorable contracts. So when you look at, and then this is the standard negotiated cash price that Scott wanted to point out. What we need to do is show this allowed amount at $2,460, but then we need to also include, and we included just a 25% blended rate. It could be 20% or 30%, depending on the time that they pay their bill in full. So there's an incentive to actually pay for the service. We're going to take a discount of 20 to 30% off that 2,460. So really what's out of the pocket of the, what the allowed amount is going to be is 1,845, which puts us very competitively with the other. Now, if we do need to reduce the charges on that, we'll go through the analysis. What is the financial impact? How much volume do we think we're going to get back? And what we would do is replicate this 100 times over for the top codes in every single department, especially the ones that have commercial insurance, except, and here's the big except that I want to make sure the board is aware of. We're going to have a problem with surgery. And the reason why we're going to have a problem with surgery is the way that we bill surgery at this facility is based off of minutes. It's not based off of a fee schedule. It's based off of minutes. And so comparing other facilities of what they would charge or what would be the out-of-pocket responsibility is we're just going to have to base it off of our history of performing that particular surgery. Then apply the discount and give people the opportunity to make a decision. It's very difficult to do CPT codes in the OR for us compared to other facilities because our methodology of billing is different. Right now, we do by time in the OR.
Is that so we can use time to get us to Medicare surgery? Or does it matter?
No, it doesn't matter. Okay. It's just a methodology that we adopt.
So changing the methodology is acceptable if it is more favorable?
Well, we'd have to, we haven't considered changing the methodology in the OR. If you go to an ambulatory surgery center, they don't have a CPT code, but what they've negotiated is a fee schedule for each CPT code by that particular procedure. It could be that Dr. Cowan is in a hernia for, how long do you think the average time is for a hernia? Hour, okay? Are there times where you're in the OR for an hour and 15 minutes? Because of, you're in there and you're just having to deal with some, they might start off as it being endoscopic. They get in there and like, you got to open this dude up. That takes a lot more time, and that's why we bill by the minute. Is, sometimes surgeries do take longer, sometimes they're shorter, but
Double volume to be able to.
Yeah. The OR is the one caveat that I want the board to be aware of in us being able to look at that allowed amount and be able to have that true apples to apples comparison to other facilities.
There's a lot of times where the surgeons are baffled by the fee that we do charge for the services that they're providing. Is that true? I'm speaking for you.
I couldn't.
Sometimes you're baffled by the amount we actually charge for the surgeries. Like a colonoscopy.
I think it's rare we ever find out, to be honest with you. I have no
Like
idea.
if it's made it
what
on
it's
Facebook or we bring it up in a board meeting. You're like, what?
Meaning the gross.
Yeah.
The gross charge.
Gross charges.
And, well, I've been encouraging them to operate slow.
Right.
Try to help.
Well, every surgeon knows that it's there is a quality aspect to how long that person's, on the table.
Totally.
And so.
I just don't think that it would
That's
be
a-
a bad idea to be thinking that direction. You already told us that surgeries are unelastic as far as the spectrum goes.
Well, I said with the caveat that the more that a procedure can be done in an ambulatory surgery center, it moves towards it being elastic. And the more complex it is, so for example, there are a lot of patients that would say, I want the surgery done by Mark Callan, or I want the surgery done by Sam Linford. That is their deciding factor.
Yeah.
It's brand, it's quality, it is who they have the trust and confidence. That's why the elasticity on surgery, it becomes inelastic.
Like we got the letter from Dr. Stuckey. Everybody got the letter from Dr. Stuckey.
Was it your name?
So you got a letter.
Hospital email?
And I think it was an employee of the hospital.
Yes, got it right.
Yeah.
Anyway, what I'm saying is, if the surgeons wanted to think about this themselves and come up with a fee that they're comfortable with based on the average amount of time it takes, and I understand. Sometimes it's 15 minutes more, sometimes it's 15 minutes less. I think it's worth giving them the option to look at it.
Yeah, so Dr. Stuckey, I mean, one of the reasons why I'm proposing this is because of the weakness that Dr. Stuckey pointed out. Did you see the good faith estimate that we provided the patient? When I looked at it, I was like, excuse my language, but this is crap. Is that inappropriate to say?
No, not after.
No.
That was hammers.
So anyhow, there is.
So that wasn't gonna pan out and be within $400 of what the actual surgery was.
Well, so what I tried to find out is like, okay, we put 2 CPT codes, and what they did is they treated that 2 CPT codes as 2 separate surgeries, not
They,
when we,
provided-
whoever provided the good aid assessment, I don't have a name.
I don't wanna know,
What's that? It's a system, right? Okay, so
I
it's,
wasn't like trying to
yeah,
call out.
the system. So we're having discussions about, okay, we're not doing ourselves any favors. And that was Dr. Stuckey's point. Dan, you need to be aware of this because this is a patient that just got this as a good faith estimate.
That's what I'm saying, if a surgeon that's performing the surgery is like, a junk.
Well, normally the surgeons, they don't get involved with the charges. It was just, somebody brought it to their attention and they wanted to point it out.
Yeah.
But we do need to address it though. It is feedback to the organization and we have to address it. And this is my proposed solution for addressing it.
So, when we were talking about giving some of the good faith estimates for a while now up front, in my experience since being on the board, we have never been able to be accurate with giving an estimate up front. And I don't know why, but we haven't. I mean, that's something that I've heard regularly. And it seems like I get reassured, yes, we have software that can do this and this and that, but inevitably, it's something like this that comes up, that it's like, so my faith in us being able to provide a good faith estimate that we can stand on is lacking there.
There's
Just
not a lot of
because we haven't been able to, and I don't know why, and I'm not sure that's anybody's fault per se, but just for whatever reason, whether it's that we don't have all the knowledge on the insurance, we have issues with Epic or whatever, I'm not sure what the disconnect is there, but it seems like we've always had an issue and it's came up time and time again. And it seems like we're saying, yes, we're going to do it correctly, but I don't know, until I see it, I have a hard time believing it.
No, so what I'm saying, Nicole, is I agree with you. And it has to be addressed. We have to get to the point where you do have the confidence.
Dr. Cal, this is for you, that relates into this subject of giving good faith estimates. So say take a hernia surgery. Do you have any idea as to what the percentage of time is when you go, okay, this is going to be a straightforward hernia surgery, that's what you're prepping for, but you get in and all of a sudden, oh man, we needed to do X, Y, and Z that we didn't anticipate, the added extra CPT codes that took the surgery was going to be 20 grand, and now it's 28 because of this unexpected stuff. What percentage of the time do you see that happen, or roughly?
Suggest 20.
Okay. See, so that adds another layer of, well, yeah, we gave you this good faith estimate that this surgery was 20 grand.
That's a good point.
But we got in and, you know, you were a train wreck. So did you want us to just you back up as a train wreck, or did you want us to fix it?
Although that's probably not the problem in the sense that I think most of the time the problem with a good faith estimate is if it's too high and it causes them to go somewhere else.
Yep. Really?
Right, but you will hear, because I have heard people say, well, they said it was going to be this much, but then it ended up being this. And that was always been my question is, well,
There's
yeah,
no win. There's
how
no
many
win.
times do you get in there and they had to do these things that added these extra codes? And you know, people say, well, we was already in there, we should have just done it for free. Yeah, I took my car in for an oil change, they should have just fixed my brakes for free.
Did you new engine?
Thing.
That was
Well, Sadie, you had a hand up?
Yes. So I just wanted to let the board be aware that, there is a quality improvement project on good faith estimates that's been ongoing. When we first rolled it out, I don't know how long ago that was, we were running into lots of this kind of things. So Mallory and Sarah and her team, they meet, I think it's on a weekly basis, and they go over, hey, how many, because the rule is that it has to be within $400. That's a good faith estimate.
What has to be within
The estimate has to be
To
within
what the actual bill
$400
was?
to what the actual bill was. Yes, unless there is some sort of change in the procedure, like they go
Some
and they
unknown
come
thing.
together. Yeah, yeah, so they meet and they go over it. Our numbers, and I don't have them on hand, but they have significantly gone down. We're doing a lot better than we used to be, and we are continuing to look at it and monitor it. Just wanted the board to be aware of that.
But it's still, I don't think it's to the point where it can solidify that confidence that you're looking for.
So, and with that, I do want to recognize that I do believe that there's been a lot of improvement in this area. It's just the one thing that I see is, as we talked about within the community and people going elsewhere, we have stuff that comes up and we're like, hey, come give us a shot again. We got one shot, right?
Yeah.
We mess up again,
Yeah.
they're not coming back. And so we've got to get it right the first time. And I know that we're working on it. It's just, we've got that one shot to make it work and to get it back on board and keep them.
It's a very great point.
So it's just a concern that I've had all along.
No, it's a great point.
And Dan, I'd like to commend you on this approach. I think this is going to solve and remove a lot of layers of ambiguity, because that is the hard cost we're talking about, this allowed amount. And that's what I try to tell people when they bring stuff up is, oh my gosh, they charge this, and I'm like, yeah, but you don't understand. There's still what your insurance allows, and that's all they're going to pay. The hospital then can't come after you for the difference. it's contractually not allowed to do so. And so I think it's this is what needs to happen.
So let me
If
finish.
you go, I want to look at this example. I got to make sure I understand.
Yeah, so let me finish it. Let me finish the explanation here, okay?
Jeff, did you have a question?
We can wait till after the.
Okay, so the net patient obligation, is that the patient obligation or is that the insurance and patient obligation on that?
That is the same, that was a pro forma look at what is the standard negotiated cash price. It's the same amount for each of the other facilities, except this includes our new discount policy being increased. So that would be the net patient obligation, or the same thing as the standard negotiated cash price.
Okay, so this is just the patient responsibility.
Yeah, it's the same as the negotiated cash price line, except for ours, because we're going to increase our paid in full discount.
Yeah. So the importance of the discount policy is that that's where our leverage is to really be competitive with the consumer.
That's a price reduction.
That's your price reduction. Now, if we do need to decrease the charges because the price discount can't even get us to the point that we're competitive, then we're going to have to consider doing that. But what Scott and his team have done is every area of the hospital, they've looked at the top 20 volume codes, the most utilized codes. And if we need to go further than that, we're going to. But what we want to do is reproduce this 100 times over so that we know and are very confident that if they pay the price, now that's the kicker, guys. You got to pay for the service before you get the service, or very close to after the insurance settles. If you don't, then there is going to be.
You don't get the discount.
There's the discount. The discount is where we're going to be competitive, and we're willing to offer it, but it needs to be tied to the incentive that we get our cash. Because if we don't, we can't stay in business.
What's the typical procedure when we've estimated, we've had to think on the fly, and we've changed? If we've collected money in advance of the surgery based on a good faith estimate, do we still say, oh, no, the procedure is understandable?
We refund it.
Well, no, there is a possibility that could be.
15-minute more surgery, they're $8,000 more charge.
But then they would owe more than that estimate they paid up front. That's the way.
And I think
They got the discount estimated.
I think the point is what this is a very valid point. I think on the estimate we need to spell that out.
We do.
This is only an estimate, right?
So if it comes out more, then.
Because it could come out less, and if they pay more, then obviously we're going to pay them back. And that's just the way that we're going to have to do it.
So on somebody that's willing to pay cash, you're asking for it up front before this procedure. Is that what you're saying?
If they want the full 30%, okay, so it's 30% if they pay in full before it happens. It's 20% if they pay in full.
Okay, so my questions are, remind me again, I know you just went through this about 20 minutes ago. So we've got our gross list charge, that's what we're showing on our CPT code. Standard allowed is the insurance reimbursement based on contract, or is that for both patient and insurance company?
It's between the provider and the payer. That's their contract, right? And that's what the allowed price is.
So we're going to get 2460 because that's our contract.
With Blue Cross or with Cigna, that's how much they'll allow.
Well, let's assume that, okay, whatever company it is, they're going to allow 2460, and some of it's going to come from the patient as their deductible or whatever, and the rest of it comes from the insurance company.
And usually
but that's the total amount for both parties.
And usually what happens with the deductible is the insurance says, we'll start paying Star Valley Health after you've met your deductible, right? So you're responsible at the beginning of the year. And so in that case,
maybe that whole amount.
So that's exactly right. With high deductible health plans that are in place, a patient is very sensitive, like, holy freaking cow, I'm gonna get this MRI, and I'm gonna have to fork out, $1,800. Well, my family budget doesn't have $1,800 right now. So this is why I need to kind of get it for $750. And the answer is, yeah, you probably could get an MRI in Logan or at a freestanding imaging center for a lower amount. Are we going to compete with that? Or Evanston? And the answer is our hospitals will always be vulnerable for lower cost settings.
Okay, so what's the standard allowed percentage?
That is the,
85,
that's the percentage that the allowed is of the gross. So
Okay, so
basically that shows you
that's just
the
percentage.
aggregate contractual between the payer and the provider. So it's
So
interesting.
in our contract, it's 85.4% is our standard allowed. And that's how you come up with the 2460. And then the standard negotiated cash, we've decided that. I mean, where does that number come from in 2017?
Just says for that CPT code.
That's what we'll take for a cash.
That's our standard average cash price if that was paid as
They
cash.
come in and ask for a cash price, we're gonna tell them 2017.
If they're uninsured or they want to do something outside of insurance, that's what they
So
will
they're
pay.
premium.
So if you look at that,
What's that?
How do we know everybody else's?
Because they have to put it in, they have to disclose it.
disclosed.
How come their cash price is higher than their standard allowed?
So it was on, that's on Ermac. Yeah. Ermac, well, St. John's Bear Lake on this.
Okay, then the cash discount is our 25% being applied to the 2,000. Is that correct?
Yeah, this is, yeah, that's as if we were to provide that now going forward, if we agree on our discount
Okay, so
policy,
that
it would
gets
bring us
to 18.
really, into.
Okay, and 18 is actually only 97% of the median.
Which is below the median.
So what
I don't
really,
think I understand the number.
so now what happens, guys, is, let's say they've met their deductible. They had something done in January, February, March. They come to Star Valley Health for, I need another MRI. The good faith estimate that we provided them in January, February, or March is going to be very different of how much they owe. Why? Because they met their deductible. So depending on the timing of the patient's encounter with our system, that good faith estimate is going to change. So you can't, the shelf life of a good faith estimate, it's really short of what they're going to owe. And that's an important thing that I want to point out.
Speaking of course, this assumes people will maybe read what's on the estimate, but if one of the goals of educate is to educate, it might be worth disclosing that if your deductible hasn't been met and it's going to need to be met at some point anyway, you might as well take advantage of the discount now.
Yeah,
Sure.
yeah.
That would be
Absolutely.
a good disclosure to put right on the estimate.
You know what? Let's make note of that.
You can't say that to them before they book a procedure though. That's illegal.
Say what?
You can't say that?
No, according to your law stuff, I read through Dale's document.
Oh,
You can't-
so
you
the
can't,
advertising,
Yeah, right.
you're absolutely correct. We have to be careful with that. Well, no.
You can't induce them to the surgery
No.
to meet their deductible.
Well, hold on, let's differentiate.
People can advertise for you, that's legal, you just can't advertise.
Well, so let's differentiate. We can do all the advertising we want with commercial insurance. What we're talking about as far as the discount is the uninsured. We're going up to 45%. That is what so this cash price, that's what we're going to talk about in the executive session. It doesn't apply to commercial insurance.
Plus, I'm not suggesting that they get the surgery.
No, I know that.
They can meet the deductible, which I think is illegal. I'm just suggesting.
In bold, it
If you
says,
can
hey,
state, hey, if you haven't met your deductible, you might want to take advantage of the cash discount that's available now. The other thing, I guess, I'm just curious from what you found in the research, if you have. Because I get all the math, I see where you're going with it, I'm supportive of it, but I'm looking at some other pillars in the equation. People like choice, no matter what. and there are some that no matter what you do, you're never gonna win them over. And if we are dependent on a certain percentage increase to offset what the discounts are that are being offered, is there even a market share available to capture in our valley to get you where you need to be for the break-in?
You nailed it, as we look at this analysis, and you say to yourself, well, let's just reduce charges by 20% and hope for the best. The likelihood of us capturing in a market a 20% increase?
Yeah, not gonna happen.
Yeah, so that's why I say reducing charges, guys, it's not gonna, it's only gonna hurt you financially with a very low likelihood based off of research that you're going to recover that volume based off of price elasticity and the market, to your point. Where we need to win the day is they're out of pocket for their circumstances at that specific time. Whether they pay the deductible or not pay the deductible, we gotta have the conversation and the argument at that point. Nothing up here in this charges crap. Sorry, I said crap twice now. I'm heading down the wrong road. So that's where the rubber hits the road.
So this example though assumes that we're the only one offering a cash.
You're correct. You're correct. No,
No, it doesn't.
No.
The cash discount that your cash discount generally would be the difference between their standard allowed and the negotiated cash price. The difference there at Bear Lake, let's say at Bear Lake is, I'm looking at several of them here, but it's between 10 and 12%. That has to be the cash discount. If you do ours is 15%. Guess what? That's our cash discount.
but we're gonna.
That's the difference between, I'm looking at another example.
So
here.
you're saying that
You can kind of imply how much discount they're giving by just looking at the number, the difference between the cash price and the allowed price.
But not the paid in full discount.
let's be clear. We don't know.
Right.
We don't know the paid, they may offer an additional paid in full discount.
They could, but then it would be reflected in that negotiated
No,
lowest.
I don't think so. Does it have to be?
Yeah, that's what it is. That's their lowest negotiated cash price.
So we're going to reflect,
we're
reflect
going
our paid in
forward.
full discount on our cash listed price.
Will go down.
Okay.
By definition.
So by definition, we have to disclose our paid in full discount on that cash
You don't
price.
have to, it's not called a paid in full discount, but it will say that's our lowest negotiated standard cash price for that CPT code. And that's where it's derived from. Where else would it come from, other than you're given a concession on the allowed price? So you can see it's between 6 to 15 to 20%, depending on the CPT code considered, by facility. But we want to be richer than that to be very competitive.
So, but that would say then that St. John's does not offer a
Right?
discount?
No, we're not saying that.
I'm not saying that.
We're not saying, most hospitals do offer, what we're saying is whether they call it a paid in full discount or just a cash
Price.
on the barrel discount, whatever they want to categorize it, they still have to show what their lowest cash price is.
But it says 24.55 is, yeah.
That's why I was asking on that
Yeah.
specifically, is it comes.
It's because it says the gross list charge is 24.55. Standard negotiated cash price is 24.55.
let me-
That's not showing a cash discount.
Well, that's what they disclose.
And that's my concern here,
Yeah.
honestly.
So maybe there isn't. That's what they disclose. I mean, that's all we know.
So, and that's where I'm going with this whole thing, honestly, regardless of my concern is we're making our decision based off of what we can, derive as what's being disclosed, right? What we don't know is what's not being disclosed.
Yes, right.
And so what I mean by that is, and maybe I'm not fully understanding it. I didn't realize that if we make the adjustments, it's going to go into our standard negotiated cash price in there. But I just, it just makes me wonder because to that point with St. John's, I don't think that there's.
But Cole, what other alternative do we have?
And I'm not saying that. I'm just saying I think we need to be cognizant of this going forward, that we don't necessarily always have all the information.
Fair.
There's stuff out there.
Fair.
We have what's required by CMS, and here's what CMS requires. by definition, is that standard negotiated price is a consistent, discounted self-pay rate that functions like a negotiated price without insurance involvement. That's the definition.
Do you
No.
have,
If
you have to
they,
run the procedure for a time period and then you can see what your average charge was on
well,
that?
you have to update that that machine readable file
Mhm.
annually.
Yeah.
So I did, my thing is like, you know, that is why I was asking, like say, St. John's exact, for example, is basically they're saying that they're taking their gross charge on there, but I know I'm hearing from other people that they're not. And so that's where it's like, you know, back in my mind, I'm thinking whether that's disclosed or not, there's gotta be some sort of discount there, right? And so I don't know. Anyway, that's why I'm asking and bringing it up, because I think my concern is there's stuff that we don't know about. We're gonna make decisions.
It's fair, but it's the best information that we have available.
And I'm not arguing that, but what I'm saying is that we just need to be aware of that. It may very well impact, that type of stuff may impact.
The ultimate decision by the patient.
What we might actually get
Yeah,
back.
I agree. And we have to,
So
so take it with a grain of salt, and we just have to be, we have to be careful and look at it. So if somebody leaves and they say, we found a better price, well, we'd like to know why. Let's have a discussion.
Right.
So Cole, I'm just trying to understand, I mean, all we can do is what we can do, and we can only control what we can control. So, you know, if we do this and we give them that cash price, then it's up to the patient to shop around. And then if they're, you know, if they find a better, that cash discount price, that's not on us. We don't need to tell them exactly what the cash discount is.
No,
at St.
but-
John's. That's not our job.
I'm not saying it is a no, but what I'm saying is we're making these decisions assuming certain things, right? Assuming that, you know, just to the point of like, hey, if we discount this, you know, X amount, put this policy in place, cash discount, we're going to recoup this much, or we're gonna draw these patients back. What I'm saying is, I think you need to take whatever you think you're gonna draw back and maybe discount it a little bit for the stuff we don't know. Because these other guys, I don't know how, I don't know if it's possible or whatever, but I've heard, and take St. John's for example, I've heard multiple times that they give discounts for cash prices. So again, I know we can only go off what's disclosed, and I'm not arguing that, and I'm not saying there's anything wrong with how this is put together. I'm just saying we need to be aware that if we're thinking we're gonna get 5% volume increase on this because of the cash discount, we need to know that it may be 4% instead of 5% or 3% because there's some unknowns here.
Yeah, I don't think I've heard Dan bring up that, hey, we expect to get 8% of our patient base back.
No,
I'm just saying we need to take it into consideration.
Right.
So, yeah,
I will acknowledge, Cole and everyone, this is still imperfect. It's imperfect for St. John's trying to figure this out, right?
Right. No, absolutely.
And they could change their cash, they're paying full midstream, and we're like 12 months lag on what they're really posting, right? So it's going to be imperfect, and patients are going to have different pieces of information to compare and make a decision. What we need to do though is just try to get a better understanding. Are we in the money? Are we somewhat close to being competitive with our peers? Not, and again, I'll acknowledge we're never going to be competitive with the ASC.
No, and I'm not arguing to or not to do this right now. I'm just saying this is something.
Let's acknowledge it. Let's acknowledge it.
Because we don't have all the details, and we can only go off on what we have.
So Cole, I think, you know, in this discussion, you look at two groups of people. Those of you that have insurance plans, you have a fixed cost. Absolutely have a fixed cost. You got your deductible, and you got your co-insurance and co-pays. Okay.
And max out.
So that's something that you should understand. Okay, I got $5,000, I got $3,000 deductible, and I got a $6,500 out of pocket. Right. That's on you to understand that.
Right.
Now, where this would really come into focus is those that have no insurance whatsoever. Then that's like, no, 100% out of my money.
Right.
All the time, all year long,
right.
No changes. You guys have that fixed cost, right?
Right.
So and that's part of that education. You know, like with people on the deductible. But sure, you can drive down to Logan and get that MRI for $550 cash. So they're not going to bill your insurance. So you got to think to yourself, if I'm getting an MRI, there's probably a problem. There's probably going to be some expenses a little further down the road here.
Right.
Is that going to come into focus this year? Should I be putting that money in a bank account that's going to help me for the event in February that's gonna help you in September. I mean, and that's what you can help educate people on is, sure, you can do that. It might not, you know, it's not gonna move the needle on your deductible if you need that later this
Right,
year.
and I guess that's where I'm kind of going, is that like, we're talking about giving cash discounts, bigger cash discounts. I guess what I'm saying is, I mean, what's to say that St. John's not doing the same thing for the uninsured?
Yeah, right.
Right, and so I'm saying, so if we're,
But all we can do is give, hey, here's what your cost is gonna be here. Would you like to use the people you know, stay at home? If not, shop around and it's on you figuring out what's.
right, but if we're making a decision, think off the number, thinking that we're going to bring them back because of the cash discount, I think that's dangerous.
I don't have, I wouldn't be planning on a number on that.
I don't know. Again, I don't know if anybody would know that. The only data I can find to just predict that is this is elasticity analysis, right?
Right, I think we've got further into the weeds than I wanted to do, I just wanted to bring it to everybody's attention, I think this is important, we're cognizant of this.
All right, summary. We're not trying to be the lowest cost provider everywhere. We are selectively competitive where patients have choice and disciplined everywhere else. 2, targeted pricing is about protecting margin where demand is inelastic and competing on price only when we think it's going to change patient behavior. 3, SVH needs to change its good faith estimates and all other messaging toward allowed amount combined with pay in full discounts. That is the gist of what I'm trying to share with the board. Thank you. Any other questions?
Take a 5-minute break, please.
You know, I put a whole box of that, or a box of ham.
I want to.
Our meeting's back in order. Call the meeting back to order. Is that what it is? All right, FYI, somebody want to discuss that one? This is the board training in Sheridan.
We have two members of the board that are going, Cole and Clint, and I'm sure that they'll come back with some notes to share with the rest of the board.
Yeah.
He points to Cole.
Did you hear that? What he said? You're coming back with notes? Okay.
Yeah. You wanna go, Jeff? Just because I noticed Clint is really being reflected.
Whatever
I
that's
will,
doing,
I'm actually traveling on it.
They missed their text chain earlier. So, yeah.
Okay, any questions on that? All right, we'll move forward. Did you want an executive session?
So
We need to make a motion.
I make a motion, we'll move into executive session.
Litigation, legal issues,
Real
real
estate,
estate
legal,
acquisition, personnel, safety,
And
security planning.
we have that motion pre-printed. Do we need to add anything to that motion?
If we're gonna discuss what I think we will, it should also include safety and security planning, that if disclosed will pose a threat to the life of property, and to discuss security.
That's not a non-blowing comment. Is that what you read?
Yep. Okay, I assume that was your motion, Clint.
Exactly my motion.
Also good.
And I heard a second. Cindy? Any further discussion? Okay, all in favor? Aye. Okay, we need to give
Just a second.
Kristen a few minutes. Let us know when you're ready to